So I will just restart. So we have a diabetic, hypertensive patient, 55 years old, controlled, planned for elective inguinal hernia repair. Okay. So we are trying to chalk out what are the concerns in this patient. So age, I will better use the word demographics. Okay. Because demographics will include everything.
Right.
Okay.
So,
Uh,
someone's mic.
yes. I will just try. Actually, please, all of you mute the mic. Okay. Yes, Zishan, please continue.
So, he's a middle-aged man. 55 years is a middle-aged man. And according to history, we know that his diseases, his comorbids are under control with his compliance with his medications. So first of all, if we take, first of all, we have airway concerns in diabetic patients.
Okay.
There can be the glycosylation of joints. So for that, we have to check for the prayer sign and see if his neck movement is fine. Uh, then in diabetes, we have to see which kind of medications he's on. Is he on insulin or is he on oral hypoglycemics? Then we have to like we have to guide him which medicines are to be stopped or if his medicines have to be continued
Okay.
in the perioperative period.
What else?
Same go in the diabetes.
No, no, I have given you a
Okay.
scenario.
Then,
You have
yes, sir.
already appeared
Sure.
in the exam, so you know. Okay. So just try to focus. You have 5 minutes. In 5 minutes
Mm,
maximum, this is 5 minute scenario usually. Okay. So you
yes,
exclude 1 minute for the questioning. So you are left with only 4 minutes.
yes,
Okay.
sir.
So just keep this thing in your mind, and then we will discuss what are the deficiencies in your answer.
Sure. Then same goes with the hypertensive medications. We'll see which kind of medications to be stopped or not, or continued in the perioperative period. Then in the for investigate while examining the patient, we'll see for the end organ damage, which we can see in the eyes. In his for diabetes, we can see the autonomic neuropathy and uh, then other things like in his heart sounds or his shortness of breath on exertion and all those things. Then in investigations, we like to investigate about his HbA1c, and we'll like to have a full blood count just for his hemoglobin levels, and RFTs are good, and ECG is needed. Other than that, if something suggests in the history or his physical or his examination, we can go for an echo or a cardiac review.
Okay. What else?
Then
You have already
yes, sir.
used
Okay,
almost
we are
more than 2 minutes. I'm not interrupting
yes, sir.
you, so that you
So
should have, because this is the mistake which we do in the exam. Okay, so please continue.
yes, sir.
So now in
Sir,
between the
then
questions will be, why will you do CBC? Why will you do RFTs? Why will be you ECG? I'm skipping it them for a while, and we will just come back.
yes, sir.
But still,
Right.
just try to focus, because you are going on the wrong direction, I suppose.
Mm. Then, sir, in the perioperative period, for the induction, we'll have to consider for the pressure response of laryngoscopy
So you
and
did not, you don't want to discuss what is your plan, GA versus regional.
sorry, inguinal
Would
hernia,
you
of
like
course.
to
Inguinal
know
hernia can be
whether
done
it
in
is laparoscopic versus open?
yes, sir. Right. So the surgeon can guide us, of course. If he is going for laparoscopy, then we'll go for GA. If he is not going for laparoscopy, we can opt for regional anesthesia if the patient
Okay.
is fine with it.
So
And
discussion with the surgeon. Okay.
surgeon, yes, sir.
And just because we will just interact now. Did you evaluate? Did you use the word evaluation on the basis of history,
English.
examination, and relevant investigation?
No,
Okay,
sir.
you don't need to tell that I want to do prayer sign. Okay,
Yes.
this is actually, this is not the domain of table viva. This is domain of
Right.
long case, for example. Okay, so you just have to see that we have what are the challenges, as we said, the demographics. So I will be looking at anything related to the patient, anything which is relevant. Number one. Uh, Number two will be diabetes, and number three is hypertension. So there are, I have repeatedly told you the word macrovascular and microvascular complications. You don't need to separate diabetes and hypertension. Okay,
Yes.
this is a patient, real time patient with you, so you should have to use minimum time, minimum words. So you have to see the microvascular, macrovascular vascular complications because of diabetes and hypertension, which will be in the form of cerebral vascular disease, ischemic heart disease, heart failure, autonomic neuropathy. Okay,
Yes.
what
Renal
else?
dysfunction. Renal
Airway,
dysfunction.
airway,
Airway.
renal dysfunction.
Yes.
Okay, and so you will be evaluating whatever you will be doing. You don't need to tell that you just have to, first of all, you have to tell that these are the things in my mind, and I will
Right.
evaluate on the basis of history, examination, and investigation these things: cerebrovascular disease, ischemic heart disease, heart failure. Then, if the examiner wants to wants you to tell, he can ask you, and then you can say there will be some history of TIA. So I will confirm it with Doppler. Okay, I will confirm it with CT scan, MRI. Okay, so this is one
Right.
thing is covered. For ischemic heart disease, I will have some history, shortness breath, and whatever, and then I will be doing ECG. And if there is some problem in ECG, I will go for echo, or I will do some stress thallium. Okay,
Yes.
and if it is significant, then I will refer for angiography, and uh, we will optimize the patient. Okay, so this is how you have to approach. If the examiner wants you to probe further, he will ask you. Okay,
Yes.
so similarly, renal dysfunction in the form of the classical sign symptoms of renal diabetes, that is actually practically none, it's not related much to you. It is polydipsia, polyuria, which you use. So in the table viva, you are not required to tell these things. Okay, so renal dysfunction will be in the form of raised creatinine.
Right.
Okay, and similarly, if you are talking about, for example, what else is left? So you will be focusing on the autonomic dysfunction. So autonomic dysfunction will be in the form of, for example, you will be evaluating again the same thing, that what is the how to evaluate. And
Sure.
so evaluation will be in the form of, what will be the autonomic dysfunction evaluation? You will have some resting tachycardia. Okay, you will have signs of fullness. Okay, because of gastroparesis. You will have then further on investigation, you will be doing ECG, and you will find loss of RR variability. You will have some history of orthostatic
Hyper.
hypotension. Okay, so what will be the result? What is the business end? You will be saying that I will be suspecting swings of blood pressure. Okay, so this is how you need to tell. Okay, so similarly, what will be what else will be there? So if we talked about heart, we talked about kidneys, we talked about brain. Okay, we talked about, you can say about lungs. This will be related, interlinked. Okay, so if there is some so you will use the word evaluation, and you will say On the basis of history examination, I will be evaluating, and if there is anything need to be, what will be the result? That anything need to be optimized or not. Okay. So you don't
Yes.
need to tell everything. Similarly, in diabetes, as you told, insulin versus non-insulin. So as an anesthetist, what is difference for you? Not only that you have to control and shift from a non-insulin to insulin. There is what is significant that insulin dependent diabetes mellitus is a risk factor. Okay,
Yes.
you know that it is among the intermediate predictor or clinical risk factor or Lee revised risk cardiac risk index we were about. Okay, so similarly, about other medications or antihypertensive, similarly, you will be expecting the what will you be expecting in a hypertensive patient? Swings again, swings of blood pressure, okay, and some of the side effects of individual groups or as a whole, these patients will have two issues which you should be thinking in hypertensive patient regarding that preoperative control, that how much is it should not be in class 3. Okay, it should not be in class 3. If it is in class 3, you have to optimize them. This is number one. And number two, these patients are relatively hypovolemic. Okay.
Yes, sir.
So
Is a question.
you should have to maintain the volume. Otherwise, there will be sudden hypotension, exaggerated response to anesthesia, both in GA and regional. Okay. So like, for example, if you give a spinal to a normal patient or a patient with hypertension, you should expect that there will be more, there can be more severe hypotension in hypertensive patient. Okay, so more severe hypotension in hypertensive patients. Okay, so
Yes.
this is how because this why I'm again, maybe repeating again and again that this will be asked in exam definitely, diabetes and hypertension. So you should be for retinopathy, for example, you saw told about retinopathy. You just have to say that if there is any history, you will refer for fundoscopy.
Yes.
Okay. And one thing I missed regarding hypertension, that you will be expecting the autoregulation curve to
Shift like a high.
cerebral autoregulation to right, shift
Yes.
to right. Okay. So you have to look at the ward reading. You can use the word ward reading, or if you are in international exam, you can say that you have to consult the GP, what are the normal blood pressure reading, and you don't have to move more than 20 to 25% maximum off in either direction. Okay.
Yes.
So this is regarding the readings and control. And for renal, what will you do? We said that creatinine will be high. So what is the business end? Business end is that this is a renal risk factor. So you will be avoiding the further aggravating factors. Like you will be avoiding hypotension,
Volume.
hypovolemia. Okay. You will
Yes.
be
Yes.
giving NSAIDs with caution. Okay. What else?
Other nephrotoxic drugs like antibiotics or
Nephrotoxic drugs, you will be avoiding nephrotoxic drugs. And similar, not only in addition to the medications, these patients may have some electrolyte imbalance. Okay, so you have to, if there is borderline renal risk involved, so you will be taking care of these things. Because you're further, if you tell these things in start in an organized way, maybe even you can cram the answer. Because this you have to speak out definitely. I can guarantee you that no exam anywhere in the world will be finished without these things. Okay, so you can prepare your answer, and then in this case, because now you have to organize this thing, then you will be saying that first thing will be evaluation, Second thing will be optimization. Okay. And third thing will be if any referral needed. Okay. What else? Actually, I made this. Just a second. I had shown. I have closed this document. I will find it. I don't know where it is it now. So whatever you have told, the evaluation. How much is the condition of the what is the condition of the patient? Any optimization needed? Any referral needed? Then discussion with the surgeon about the surgical plan. Okay. And then you will be preparing GA versus central neuraxial block versus, in this patient, peripheral nerve block, with on the basis of will be laparoscopic versus open. Okay. So if this is purely elective, even then in inguinal hernia, what you should be knowing that whether it maybe it is reducible versus irreducible. Okay. Or like irreducible, maybe obstructed or incarcerated or gangrenous. Okay. So because if it is there, then this is not elective surgery. This is emergency surgery. Okay. Because it will result in gangrene.
একটু
So
শুইলাম তাতে তোমাদের প্রবলেম হয়ে যাচ্ছে সারাক্ষণ 7টা ঘন্টা দুপুরে
please, all of you mute the mic so that nobody is disturbed. Okay. So on these things, you will be on these bases, you will be deciding about your plan. Okay. So now, if for example, if you the surgeon tells you that it is laparoscopic plus minus open, so what will you do? Or if they if or for example, if they say open, so what will be your plan? Yes. If they say that it is open, what will you do?
The
What are
preferred
your
technique would
options?
be the preferred technique would the option would be regional,
Regional.
uh,
Okay.
regional and GA.
For
Both are the
regional,
option.
what you should be thinking, you can immediate, these words what I'm telling you, you can use in for any patient. For regional, you need to counsel. Okay. You need to see any anticoagulants. Okay.
Yes, sir.
Or antiplatelets, and you need to examine the spine. Okay. So for regional, this is immediately you will be thinking that you have to counsel the patient, you have to rule out any patient taking any anticoagulants or any antiplatelets, and you have to examine the spine. This is if you are planning for spinal or epidural. Okay.
Yes.
So counseling, you can tell about or even peripheral nerve block. Okay. So you can and for example, similarly, of course GA will be there. So GA we can discuss GA as well. But so okay. So if you are talking about peripheral nerve block, what things you should be thinking for peripheral nerve block? You should have like expertise. You should have either nerve stimulator or ultrasound. Okay. Because in this era, nobody will be doing without ultrasound. Majority people will use ultrasound. So this is what, and then you have to calculate the toxic dose. Okay. Versus anticipated complications, both for peripheral nerve block as well as spinal or epidural. Okay. So,
Right.
and for example, if you have given GA, even for open surgery, still you should have an analgesia plan. Okay. You should have an analgesia plan, which may be a combination of, for example, for instance, tab block or this ilioinguinal iliohypogastric block. Okay. So what you say, inguinal block. Okay. So this is how you will be approaching it. Okay. Even if you are giving regional, there may be a concerns related to anzulysis. Okay. So you can plan anzulysis. And then now comes to GA. So if you are giving GA in this patient with hypertension, diabetes, so what will you be doing for GA? Yes, Zishan.
I didn't get what you're trying to ask.
And now you are giving GA to this patient for laparoscope. Forget about laparoscopic. You are doing for. I'm going step by step. So if you are giving GA in this patient, what will be the considerations?
NPO consideration
NPO,
for diabetic patients, the gastric reflux
airway,
consideration, then airway,
uh,
aspiration.
this one aspiration risk. What else?
Then swings of blood pressure.
So what will you be doing now?
We'll be confirming if the patient, if the NPO is proper,
Okay,
if the patient has any history of GERD,
okay.
we can
Now
provide
we
him
have
with
discussed all things.
NSAID
Now,
prophylaxis.
now we are giving the anesthesia. Okay.
Yes,
So
sir.
this we have already covered. So now
Okay.
what will you
We'll
be
give
doing?
NSAID. We'll be giving NSAID prophylaxis 30 minutes before.
Antacid. Okay.
Okay, and headaches and
What
active
else?
receptor blockers can be given.
The rapid sequence
Then
induction versus modified rapid sequence induction versus elective like normal with the long acting.
sir,
What will you doing?
uh, rapid sequence will be good.
Rapid sequence will be good. You told that there is risk of this one swings of blood pressure. So is it a good choice? Try to say
Um,
modified rapid. It is better answer
okay.
if you have
What will
availability
be different in modified that will avoid swings of blood pressure, sir?
because you are not giving full doses. You are giving titrated doses.
Right.
Okay. And suxamethonium is is a medication which can cause bradycardia. Okay.
Yes, sir.
So this patient, you told before that this patient may have some electrolyte imbalance. So suxamethonium can interfere with that thing. Okay.
Right.
So I like you see, try to say that my plan will be according to the patient condition. Okay. Because if I do rapid sequence induction, so yes, I will be expect no problem. I have problem related to aspiration, but a little while ago you said there came maybe problem with the airway, and now you are saying rapid sequence induction. So examiner can catch you or no?
Hmm.
Okay. So you say that I will be making a plan. I will be making an individualized plan. Okay. Individualized plan. There is no general plan for these patients. And I
Right.
will, because I will expecting the swings of blood pressure. So in addition to standard 1, standard 2 monitoring, I will be going for
Invasive.
invasive blood pressure if needed. Okay. Not every patient will be required, but if you have any doubts, you can have invasive blood pressure monitoring. Okay.
Yes.
So this is how you will be telling. So as I told you before, that you should be telling about the analgesia plan. That what the options maybe we have already discussed. NSAIDs will be a little bit cautious, but they are not contraindicated. Paracetamol, okay. Then short acting opioids intraoperatively and followed by PCA if you are not giving a block. If you are giving a block, then you can use the block. You can have wound catheter. you can have this peripheral nerve block with catheter. Okay, you can with only the analgesic doses. Okay, so like you should be telling short acting, and for post operatively if you are using then you tell about PCA. And the other one I have told before, and some other medications you can say that we can use a combination of small doses of ketamine, lidocaine, dexmedetomidine. Okay, which will have better recovery outcomes with dexmedetomidine, or if you are using lidocaine, because this patient is at risk of, you did not tell about up till now, you did not use the, I was expecting that you will tell laryngoscopic stress response. This is the main thing in these patients. Okay, so
Yes, sir.
laryngoscopic, so I will be preferring, if possible, and like there is, because if you use supraglottic, what are the advantages? That there is less laryngoscopic stress response, but you said before that there is chances of aspiration. Okay, so
Yes.
you have to outweigh stress versus aspiration. Okay, so in the exam they want you to tell in this way, rather than like blanket answer that you are saying one thing only, that I will be giving this one general anesthesia, or I will put LMA, because if you told about supraglottic but you did not tell that in this patient there is risk of aspiration, or there is risk of gastroparesis, so airway will not be protected. Okay, so if you only tell that this is the thing, then examiner will be asking you the further question. But if you tell that in this patient, because we have to outweigh risk versus benefit. Okay, what
Yes.
else? What else? Anyone else want to participate? Please, whosoever wants to participate, just raise the hand. Anyone wants to participate other than Zishan? Just tell. Okay. So what else? So we have discussed, and in between, because in this scenario, if they are asking about laparoscopic surgery, they will be you can tell about. We have discussed multiple times the trocar insertion. Okay, and then pneumoperitoneum. Okay, and then the CO2 absorption. Okay, so because we are not discussing at this time, but always you can tell in this three steps: trocar insertion, pneumoperitoneum, and the CO2 absorption. This will be physical effects, this will be chemical effects. Okay, and this is also physical effect. Okay, so because it can damage any viscera or vessel. Okay, so this is how you should be answering the question. But if you answer, if you start answering in a haphazard way, then you will miss important things. Okay, so this is the default approach, because this is the one of the most common question. I am again repeating. Any question up till now? Anyone wants to ask any question, please? Okay, so I just wanted to just a second. Yes, Dr. Humera. Dr. Humera, you raised the hand, but what do you want to ask? Okay, so this is FRCA mind map. So you can, we have discussed actually everything. You can have a look And that's what I was telling you, that what is the what is the status of the patient, that if there is uncontrolled, there will be chances of complications. Okay. Risk: hypertension at induction and at recovery, and perioperative, uh, unwanted perioperative events like arrhythmias, swings of blood pressure, hypotension, as well as hypertension and ischemia. Okay. And preoperatively, they have told about the blood pressure control. Yes, sorry, I could not. The what are to rule out any secondary cause of hypertension, like acromegaly, Cushing syndrome, pheochromocytoma, like any addiction, cocaine use, things like that. Okay. So that is the actually very good source to revise your topic. Similarly, uh, just a second. Okay. So one thing I did not discuss is how to control the perioperative insulin. We discussed before when we were discussing in diabetes. So you have to. I we will discuss the I think the diabetic medications in a separate setting. Okay. So is it clear to you?
Yes.
Okay, so I think I will stop here today. And so that is how you will be approaching the patient, and you will be expecting you have to resume the oral hypoglycemic medications. You have to resume the oral medications, and we discussed yesterday about the antihypertensive medications, that which medication you need to continue, which medication you need to convert. In our next session tomorrow, I am busy, so day after tomorrow we will do the glycemic control, and if possible we will do see the glycemic complications, decay, hyperosmolar, we will try to cover. Okay, so thank you very
Sir,
much. Yes, Hassan.
sir, kindly I wanted to ask whether we can perform laparoscopic surgery in spinal. Is there any
Laparoscopic,
study or any article, sir?
actually this will be research work in your exam domain. Please don't say this, that you can do in spinal. Okay. But what is the
Sir,
reason for it? You tell me the reason.
the intra-abdominal pressure, they will venous return will be decreased due to pneumoperitoneum, and
This is second thing.
already.
This is because this will be there in GA as well. Okay. So first question is that what level of anesthesia you need to have in laparoscopic surgery?
T4, sir. Oh,
Okay. So for T4, you need to give a big block. Like you
sir,
need to perform in a proper way. Otherwise, you will not be able to cover up to T4. Okay.
sir,
So and then the second thing will be that the position they make, patient will be uncomfortable. Okay.
sir,
Patient will be uncomfortable. Patient may become dyspneic.
sir,
So even if you have covered it very nicely, the patient, it will not be very comfortable feeling for the patient. So because practically people do
right,
it, by the way, people conduct the laparoscopic surgery in spinal or epidural. Okay. But
Sir.
it's not a, in exam you don't need to go into, because in exam they are not expecting to tell you these things. It is better to play safe in the exam. Okay.
Sir, and one more question, sir, regarding 30-day mortality. If they ask whether of these GA spinal or peripheral block, is there any difference in mortality in 30 days?
I don't think so. There is any difference versus GA versus central neuraxial. Yeah, peripheral nerve block, yes.
Sir.
Because in central neuraxial block, again, you know, in exams, these are the things which I should know actually. Okay. But in
Yeah.
the exam level, they will never expect these research questions. Okay. Actually,
Right,
if
sir.
you they are asking you this question, it means you are already passed.
Sir.
Or failed.
Pass or fail, of course. Okay. Be optimistic, be positive. Okay. So inshallah, day after tomorrow, same time, we will discuss the remaining aspects of a diabetic patient. Okay. Thank you very much. Assalamu alaikum.